Okay, so welcome everyone to our webinar today. The midterms are over, implications for federal healthcare and life sciences policy. I am Ari Markinson, the moderator for today. I am a partner in the healthcare and corporate practices here at Venable in our New York office. And I've got two of my colleagues at the firm in our DC office with me. A quick change in one of my colleagues, that is that Josh Raymond, who was going to join us, had a quick thing he had to unfortunately be pulled away for, and so we've got Nick with us. And what I'll do is just let Nick and Elisa introduce themselves. So Nick, why don't you start?
Sure. Nick Choate. I'm a senior policy advisor here in Venable's legislative group in the DC office. Work with clients on a range of issues before Congress and the administration and regulatory agencies. Spent some time on Capitol Hill about 15 years before coming over here 4 years ago. Glad to be with you.
Great. I'm Elisa Halpern-Paul. I'm also a senior policy advisor in the Venable DC office in our legislative and government affairs practice group. I'm newer to the firm, having joined in January with 6 colleagues. We comprise the health policy team, and I co-chair the health policy team with my colleague Jody Curtis. We represent a range of healthcare clients, from providers to patient organizations, health and hospital systems, medical device technology companies, digital health. And I started my career in Washington 30 years ago, working for my home state senator, Dianne Feinstein, and I've had the pleasure of representing clients in healthcare ever since. Great to be with you.
Nick, Elisa, thank you. So before we make the turn to talking about next year, let's spend a little bit of time talking about how this particular session of Congress is wrapping up its work. Nick, give us a sense of how does the sort of outcome of the midterm elections impact the dynamics and priorities during this lame duck session?
Well, I guess first, midterms aren't quite over yet. As you might know, there's a Senate runoff in Georgia today. So hopefully once the polls close tonight in Georgia, we'll know pretty quickly the result of the last election. But we do know Democrats held the Senate, Republicans narrowly won the majority in the House. I think for the purposes of the lame duck, the outcome of the midterms isn't a huge factor. I think if Republicans had flipped both chambers, we might have seen a messier lame duck session. But whether really any other scenario, this was probably always going to be a busy lame duck session. Whether everything gets across the finish line or not is still very much an open question. I mean, it's December 6th. There's less than a month left in this Congress. The current funding bill runs out December 16th. So there will probably be some triage, and only those things that truly have some level of bipartisan support will get across the finish line. But I think the big two to really watch, because they are the vehicles. Everything else is going to ride along on one of those. And that's the National Defense Authorization Act and whatever the final government funding bill ends up being this year, whether that is a massive omnibus package or more of a continuing resolution with some, what they call anomalies to address things that need to change between this year's funding level and next year's. But all in all, I don't think the midterms had a huge impact on what the lame duck session itself is going to look like.
Elisa, let's turn to specific healthcare policy and sort of talk about what's on the agenda with respect to healthcare policy. What might get done, what's left to, what might get left to the next year?
Yeah, it's a good question. We could probably spend almost the full time that we have together talking about what could be on the omnibus or whatever year-end packages. As Nick said, this is the time of year. It's not just the holidays, but we often talk about what could be a Christmas tree piece of legislation, and that's because you have two vehicles moving, as Nick said, and then everyone's trying to, get their ornament hung and hooked on before the end of the year. Within healthcare, I would say there's kind of 3 buckets. There's the provider payment issues, which are Medicare, which I'll talk about in a moment. Then there's authorizing issues that people were hoping would get done earlier this year, principally when we were doing the FDA User Fee Act reauthorizations. There's some remaining items from there. And then there's what I would call the stray cats and dogs bucket, which is just anything that people, want to try to get, moved before the end of the session. And, there's a range of issues in there. There's some very important mental health and behavioral health issues. There's some smaller provisions that people are hoping to get attached. As Nick said, it remains to be seen which of these would be is going to prevail. But let's talk a minute specifically about Medicare, because I know we have a lot of providers who are with us this afternoon. And within Medicare, there's a whole host of cuts that are scheduled to come online January 1st. One in particular is what's called the PAYGO sequestration. And I don't want to get too wonky and into the details about PAYGO policy and sequestration, but suffice it to say, the bottom line, it means come January 1st, if Congress doesn't take action, Medicare providers are facing a 4% across the board cut, which is devastating at a time when many health and hospital systems and providers are facing huge increases in costs associated with workforce, associated with supplies and drugs due to supply chain challenges and inflation. So providers have come together along with patient advocacy groups and others to say to the Congress, please provide PAYGO sequester relief. Make sure it doesn't go into effect on January 1. And so far, at least from everything we're hearing, that seems to be the case, that there's bipartisan, bicameral agreement that they're going to have a stay of execution on that 4%. Then on top of that 4%, separately, in the physician fee schedule that Medicare finalized, there's a 4.5% cut to the physician services. And obviously that's a devastating amount. And Congress has in the past stepped in before to provide relief. And what we're hearing is there will be some relief, not the full 4.5%, but some percentage of that will be restored by the Congress. So that's two. Then we also have laboratory services. So lab tests, Medicare lab tests, which is how we know if people are sick or if they're managing their diabetes, et cetera. Those are on deck for a pretty significant cut, and members of Congress are being asked to provide relief for laboratory services. So pretty quickly, we're adding a lot of expensive items together in this end of year package. And then there's a number of other provisions that people are going up and asking for, like telehealth. So could you extend the telehealth provisions for an additional 2 years? And none of this comes for free. So the challenge that the Congress has right now is to figure out how much and how long, how much relief or how many items are they going to extend, for how long, 1 year, 2 years, and then what percentages. So what we're hearing is they're trying to do the math. They're dialing the numbers up and down to see if they can get to the right amount of relief for the right period of time to ensure that providers have the resources that they need. And then on top of that, there are the other issues like dietary supplement authorization for the FDA. There's cosmetics reform for the FDA. There's also lab testing called the VALID Act that was left over from the User Fee Act discussions. So there's a lot at play in a very, as Nick said, short period of time to get it done.
Thanks, Elisa. So Nick, we had, depending on who you ask, right, a outcome of the midterm elections that was expected or unexpected or to the side, who knows, as I said, depending on who you ask. But let's talk a little bit about the outlook of the overall legislative agenda into the next year, and the political dynamic that may play out and whether or not that gets done.
Yeah, I think going into the midterms, conventional wisdom, I think, certainly in DC, was that Republicans were going to take the House, and the Senate was really a coin toss. Somebody was going to be in the majority, but it was probably going to be narrow either way. Probably the biggest surprise, I'm not sure you really call it a surprise, but the biggest surprise was Republicans only picking up a handful of seats and only coming in with a 9-seat majority next year. And I think that has implications for the legislative agenda next year, because in recent history, a divided Congress can be very productive. They don't necessarily get the big controversial stuff done, but they can come together on a healthcare package, or not the Affordable Care Act, obviously, but like other healthcare items, some of which Lisa just rattled off, or an energy package. To be determined whether this Congress is going to be able to do that. I think what we're seeing right now with Republican infighting in the House over just their leadership for the next Congress is maybe a little bit of a signal that we're going to have at least a few rocky months where they might not be all that interested in legislating. Hopefully they get that out of their system and we get to a place by spring, summer, where the things that they can come to an agreement on are the things they're actually talking about. Not specific to healthcare, but I will flag a lot of what drives Congress is deadlines. And obviously annual funding is always going to be a trigger. In the next Congress, the Federal Aviation Authorization Act, which comes up every 5 years, is up for renewal. And the Farm Bill, which also comes up every 5 years, is up for renewal. Those are two potential vehicles that traditionally enjoy pretty bipartisan support. So those are places where maybe there's an opening to get something done. I think the other piece of it, and this is obviously to be expected, is with the divided government, we're going to see a lot of oversight from House Republicans. Certainly oversight of the Biden administration, of the Biden family, but of corporate America too. You look at some of the rhetoric coming from senior House Republicans, including potential Speaker McCarthy. They are very interested in hauling in companies, particularly in certain sectors like financial services and tech, and grilling these guys for their political activities, their perceived social policies. So I think certainly in the early part of the next Congress next year, we're going to see a lot of that. And whether we can get past some of that or set some of that aside and find the places where we can get agreement between the two parties is still to be determined. And keep in mind, we're 2 years out from a presidential election now too. So that will certainly be a factor in the next Congress as well.
Thanks, Nick. So, Elisa, let's think about what the House majority might touch with respect to healthcare, and what the Democratic Senate may go after.
So I think it's important to raise up that the House Republicans have been preparing to take the majority for some time, and they've been very thoughtful and intentional about what they want to do in healthcare in particular. And I think that they recognized early on, if they were taking back the House, that it would be wise, both politically and policy-wise, for them to have a proactive policy agenda to put forward to illustrate to voters and to the public generally what they were going to be advancing in terms of ideas. And I think this is because for so many election cycles, repeal and replace the Affordable Care Act was the principal focus, healthcare focus for the Republicans, and recognizing that the ACA has withstood the test of time legally and legislatively. They came together in a very proactive, very strategic manner to put forward a House GOP Healthy Future Task Force. And they had 5 subcommittees, and those 5 subcommittees did a lot of work, and they invited input from the public. It was a very thoughtful and intentional process to say, what are the things that we should be working on? What are pain points in the healthcare system? And in essence, what's the role of the federal government in addressing these issues? And for people who haven't yet had the opportunity to review the body of work that they produce, we would be happy to, when we send out the recording from today, to send links to those 5 documents. documents. But those documents really outline the areas in which the House Republicans have said they want to spend time and give attention. As Nick said, there will be investigations, and there will be opportunities for the Biden administration officials like HHS Secretary Becerra to come before the committees with jurisdiction, the House Energy and Commerce Committee, House Ways and Means, and also House Oversight, to answer questions and to provide an accounting on probably a host of issues that are going to be of interest, and not just of interest to Republicans, but I think also in many cases of interest to Democrats. They may have a difference of opinion how the administration did in those areas. But COVID response obviously is ripe for hearings and oversight. The origins of COVID, I know, is on the list. For example, the implementation of the Inflation Reduction Act, which was enacted in August, which, it's the Inflation Reduction Act, and there's a whole host of things in there that are healthcare related, specifically around Medicare Part D and the ability of the federal government to negotiate prices for drugs. The Democrats are going to be interested in that oversight because they put forward that policy and they want to see it successful. And the Republicans did not support that policy. And so they're going to want to exercise their right for oversight and to ask questions and to make sure that the agency isn't overstepping the statutory authority that it's been given. So I think those are a couple of examples. And then just of interest, CMS, Centers for Medicare and Medicaid Services Administrator Chiquita Brooks LaSure hasn't testified before Congress, I believe, since her confirmation hearing. So I think she's probably overdue for an invitation to come, up the street and have the opportunity to testify before Congress about what's going on at her agency.
Thanks, Elisa. Nick, why don't we talk a little bit about what a divided Congress sort of means for the Biden administration on a broader level? What do you think that the administration needs to do to navigate that?
Yeah, I think the biggest change for them, and I mean, not to state the obvious, but for the first 2 years, they have had a Democratic Senate and a Democratic House. So not to say they've gotten off completely free from an oversight perspective, but it hasn't been, shall we say, overly aggressive either. So that will be by far the biggest change going into the next 2 years, is with a Republican House, they are going to face an avalanche of oversight requests. And I think it's yet to be seen. We know what some of those things are: origins of COVID, vaccine mandates, borders, anything dealing with the southern border. I mean, the list goes on. The extent to which that ends up being thoughtful oversight, versus just gotcha hearings and letters fired at the administration is still yet to be seen. But one thing we're already seeing is the administration, the White House in particular, staffing up for those oversight inquiries. The past few administrations, I'm not going to just single out the Trump administration, because the Obama administration before them also had a very combative relationship with the Republican House during their last few years in office. I don't think we're likely to see the Biden administration completely stonewall the Republican Congress, but at least on some of these inquiries, we're likely to see some foot dragging. And that seems to be the norm these days. The Senate, I think, will continue to do the more traditional oversight role they would with any administration. The secretaries will come testify about the budget, issues where there's bipartisan, interest. We'll still see hearings and letters of inquiry there. I think the other piece of it is, that's the oversight side. I think the other piece of it is dealing with the Republican House in a way they haven't had to really the past 2 years. Republicans have been very relevant in the Senate to get almost any of the big stuff done that they've gotten done this year. They've had to cut a deal with Mitch McConnell and Senate Republicans in a way they haven't had to deal with the House Republicans, because Nancy Pelosi is really good at just whipping Democrats and getting 218 without much help from the other side. So the extent to which they're able to work with the House Republicans to come to deals on their legislative priorities. A lot got done this year. So the administration has a lot to do on implementation without new legislation, but there's certainly still things out there they would like to get done, and would certainly entertain deals on whether it's immigration or something healthcare related, higher education. Plenty of places they would welcome bipartisan.
PBMs, that's bipartisan.
PBMs bipartisan. Tech, I mentioned that a couple of times. There's still bipartisan interest in reining in big tech. Just a few examples.
Fentanyl, mental health, I think.
Fentanyl,
right?
mental health, veterans are always, both healthcare and other issues related to veterans are always ripe for bipartisan cooperation.
Okay. Elisa, that's where we're going to turn to you anyway and sort of talk about what types of, what bipartisan healthcare issues might we see folks agree on?
So I mentioned PBMs, so pharmacy benefit managers, I think, is an area where you have, House and Senate, Republicans and Democrats interested in looking at PBMs, finding some transparency, understanding better how they contribute to the drug pricing ecosystem. And then you also have the Biden administration interested in it, as well as the FTC. So that's a lot of different parties all kind of looking at a particular player in the industry. And I think even the PBMs themselves have said, we're gearing up for a lot of attention. So that's one. There's a number of reauthorizations. Nick mentioned some of the non-healthcare ones, but there's a couple others that are due next year. So for example, it's called PAPA, which is the Pandemic All Hazards Preparedness Act. That for many years has been a bipartisan reauthorization. In fact, Patty Murray and soon to be retired Senator Burr have a great record of working on that together, as well as right now they're trying to get a pandemic prevention response bill done. I don't even think I mentioned that in the long list of things that they're trying to do between now and the end of the year. But before the pandemic, that was an area of bipartisan interest and collaboration, longstanding in both the House and the Senate, and that's due for reauthorization next year. And then I mentioned, and I think there might be a question in the chat about cosmetics reform and dietary supplements reform, and then the VALID Act, which would change the manner in which the FDA regulates certain lab tests. And all three of those have bipartisan support in the House and Senate, and they're each very big pieces of legislation directing the FDA to do work in each of those three areas. And you can imagine a body of work on cosmetics, a body of work in lab testing, and a body of work in dietary supplements. That's a lot. Each one of those is a lot, and then you combine them. And so I think the discussion is, which of those should they do now, 1, 2, 3, or none? And should they wait to do some of that work next year? So there's bipartisan interest in ensuring that the FDA has new authorities in each of those areas. So this is just more a matter of timing, I think, than anything else, and also just the size of the year-end package. There's a couple other areas I think that are, I mentioned fentanyl, mental health, behavioral health, or bipartisan issues. Rural health is one that everyone is interested in. And I think in particular telehealth, depending on what happens in the year-end package, I think there's broad bipartisan interest in continuing to leverage telehealth and virtual care or remote patient monitoring, kind of all the innovations and technologies that are available that we took advantage of when we were all in lockdown, to make sure that we don't lose the gains that were made in those areas. In fact, just going back to the House GOP Healthy Future Task Force, they have a whole section in their proposal around innovation and wearables and technology. So I think that's an area ripe for bipartisan agreement and hopefully bipartisan action.
Great, thank you. Uh, and both of you, basically, or either one of you. So the Inflation Reduction Act, we got it around late August. It has a ton of it in it, both healthcare and non-healthcare stuff. How is the Biden administration tackling its implementation? Why don't we start with Nick?
Yeah, as you mentioned, we got that just a few months ago, but they are moving fairly aggressively on implementation. A lot of what was in there was tax related, so IRS and Treasury certainly have their work cut out for them. I believe they've already had a few comment deadlines come and go, and before they issue final rules on some of those provisions. And I think the other thing to keep in mind with implementation there is a lot of the agencies involved, IRS and Treasury, Department of Energy, EPA, to name a few, are also implementing the bipartisan infrastructure bill that passed last year. And I'm forgetting the dollar figure off the top of my head, but it was a fairly robust infrastructure bill with new programs that they have to stand up in some cases. So it's not just the Inflation Reduction Act. The administration has a lot of work to do to implement legislation that passed this Congress and get those, in a lot of cases, dollars out the door.
Right. And then on the healthcare side, so there's going to be an interesting dynamic in 2023. So we're still under the public health emergency. So we're under the declared public health emergency. Biden administration made clear it would give at least 60 days of notice before it plans to end it. So we know de facto, because of it happens in 90-day increments, that we are actually under the public health emergency at least until April. If they're not going to end it in April, then we won't hear anything mid-February. If they are going to end it in April, we'll know by mid-February. So we are likely going to see the unwinding of the public health emergency in 2023, which is not unimportant. It's like unscrambling an egg, or I don't know, another analogy, putting toothpaste back in a tube, right? Like there's a lot for the last 3 years that we've been doing in the healthcare system with waivers and flexibilities that we've all gotten used to, that it's going to take probably, more than 60 days to unwind and kind of get back to, where we were in 2019. So that is a huge thing that CMS is working on, with state agencies, state Medicaid directors, for example. At the same time, now they have the Inflation Reduction Act, which includes, as I mentioned earlier, Part D reforms and changes not just to the ability of the government to negotiate prices, but there's a $2,000 annual cap that is going to come online. There's something called smoothing, which allows beneficiaries, if they have a very big expense. So let's say beneficiary is being treated for cancer, and in January, they have a big $2,000 bill, and they don't have $2,000 in January. They then will eventually have the ability to pay smaller amounts, just like we all, those of us who have a mortgage pay a little bit every month. They will have the ability over the plan year to pay a little bit each month. But implementing that just doesn't happen, right? There's going to be implementing guidance and regulations, and they have to unpack all of that for the IRA. The HHS, and it's been covered in the media, is planning to hire 100 people to help them with IRA implementation. I read this morning that they are looking for alumni who were part of both the Medicare Part D implementation, because that was a huge undertaking, and people also who were part of the ACA implementation. These were the last two really big healthcare statutes that HHS had to implement. And so Mina Sheshamani, who runs the Center for Medicare under Chiquita Brooks-LaSure at CMS, is tasked with this, or this unenviable task maybe, but to their credit, they recognize they need to bring in people who are expert in implementing big programs like this, and then also that they need to staff up. So at the same time that we're going to be unwinding a public health emergency. So this is a little bit of walking and chewing gum, and sometimes the government isn't great at that. We'll see.
So let's deal with a couple of the questions that we've got so far. One is a very specific question about the whether or not the user fee act riders are being incorporated into the year-end package, and sort of what's the real likelihood of that not being left on the cutting room floor, or actually getting passed.
Yeah, I don't know if you have, thoughts on that.
I guess my general thought there, before you maybe get a little more specific, is we first need an end of year package that it can ride on.
Right.
But let's assume, for the sake of argument, that there is going to be something that can ride along on.
Right. Yeah, I as I mentioned earlier, I think there's a few of these user fee acts, right? So there's so the Congress finished its work by the October 1st deadline on the other user fee acts. So the drug user fee acts, for example. So kind of all the ones that were due to expire on September 30th. Otherwise, the FDA was going to send out pink slips. All those got done, which was great. And they got done in a clean way. So none of these cosmetics or valid act or dietary supplements rode along, even though a lot of people wanted them to ride along. Senator Burr, who's retiring, basically said, no, let's do a clean reauthorization, and then let's take some time to look at these other newer areas and then decide if they're going to move. So I think, I would put it at 50-50 right now. A lot of this is being discussed behind closed doors. As Nick said, it depends on the vehicle. And I think a lot of it depends on how much they're going to authorize, as opposed to just doing spending, right? So there's the spending bills, as Nick was saying, the 12, in essence, checks that we have to write to keep the government open, or a continuing resolution. So we have to somehow fund the government. Then there's all the cuts that I mentioned. So there's, they could decide to just do all the money items and do the authorizing of the more policy issues next year, or they could do, a mix and match. But I don't think any of those decisions have been made yet. I don't go to Vegas and bet on anything, I would say.
Okay, and Nick, this may be more of a question for you, but let me flip it around. The person the question came to is, I read that they may try to limit the scope of what earmarks may be used for. Sort of, what's your take on the fate of earmarks for fiscal year 23?
Yeah, I think, and this is maybe a little bit of a surprise for me coming out of the midterm results, but I think my assumption going into it is that if the Republicans flipped the House, they were probably going to get rid of earmarks. It looks like they are going to keep earmarks around in some form. They have not, incoming Appropriations Committee Chairwoman, or soon to be Chairwoman, Granger, has indicated she's looking for some reforms to the process. She has not detailed what those are. To be honest, like, the scope of earmarks is pretty limited already. So I'm very curious to see what further limits or restrictions they could even really place on that.
Yeah, I heard, and maybe this is what the questioner is referring to, that there's some concern around museums in particular, and maybe banning or limiting earmarks, or not allowing earmarks for museums. So I guess it could be further limited by the type of institution. There are some members who don't do earmarks at all, and some members who they themselves just say, I'm only doing them for government entities, or but you're right, there's already limitations. You have to either be government or not for profit. So they're already more limited than they used to be. I'm old enough to remember when we used to do earmarks, for for-profit entities too. And so one of the reforms that was put in place when they brought earmarks back recently was to say it's only for not-for-profit or government entities.
And the Democratic Senate obviously will have their own rules for earmarks that will probably look a lot like what they do today. So I would also say, just because House Republicans are doing one thing, at the end of the day, the appropriations bill is going to be a blend of what's coming from the Senate and what's coming from the House.
Yeah. And there's nothing that keeps members from creating their own parameters for what they will or won't accept.
Correct.
Right.
So another question. It's been some talk that Congress may delink the Medicaid maintenance of effort requirement from the PHE and use savings to fund other Medicaid priorities, and possibly rework and phase down the enhanced FMAP. still in play? That's pretty
Um,
specific, but any ideas?
Yeah, so this is depending on your perspective, what we call either creative funding or budget gimmicks. So yes, the last that I heard was that this was still something that was under consideration. And for those people who don't know what the FMAP is, it's the percentage that the federal government matches for Medicaid dollars, and each state has a different percentage set for it based on a formula.
We don't have any other questions right now, but I wonder if I can do a sort of 30,000-foot level question to the two of you and see what you think. I mean, we have essentially addressed some of this, but for years, frankly, there have been divergent views, right, from both sides of the aisle about how to control healthcare costs, particularly obviously in federal healthcare programs, right? One thing that's always come into play, right, is we need to negotiate drug pricing, right? And that, depending on who you are, which side of the aisle you come from, yes, no, maybe, nah, I don't want to do that kind of thing, right? The other thing that came into play and was talked about a lot in the Affordable Care Act conversation, but was sort of bastardized in the press from one direction and then explained better in another direction, was the idea of looking at comparative effectiveness of treatments and picking the right treatments and only paying for those things. And that turned into death panels deciding who could get what kinds of treatments and so forth. And it kind of got killed as a result of that. But I guess where I'm going with this is a specific question about, do we think we're going to see, whether it be in the next couple of years or into the future, some real bipartisan effort to do some smart things about reducing cost?
It's a great question. I'll make a comment about comparative effectiveness first. So one of the things that people often forget that was included in the Patient Protection and Affordable Care Act was the creation of PCORI, the Patient-Centered Outcomes Research Institute. And they were stood up and then actually reauthorized a couple of years ago. Our team actually was leading the coalition effort to get that important group reauthorized. And in that process, we were reminded as to why they were created in the first place. And it was to get a little bit to what you were saying, Ari, which is, can we have a neutral party who, nobody who has a dog in the hunt to look at different interventions and see which are better for patients, right? And the way we measure what's better for patients isn't always cost, right? It could be side effects. It could be, is it better because I can go back to work faster, or I don't have to take as much time off from work, or I can do self-care at home, right? Patient-centered, but they can do comparative effectiveness as well, and collecting a body of data that hopefully will inform shared decision-making between patients and providers, and could, but they're not allowed to actually directly factor in costs because of the political issues that you raised up, but eventually have a body of evidence that would help inform a whole host of decisions, right? What should be covered, at what rate it should be covered, what people should be recommended, what should be first-line therapies, second-line therapies, et cetera. So that work is underway, which is great. Contemporaneously, though, every year we have a Medicare trustees report that keeps telling us that we're going to run out of money, and somehow I'm closer to Medicare age than I ever thought I would be. And, I don't like the fact that they're going to run out of money. And so these are serious discussions that we have to have. The wrinkle is that we have an environment in which we have very little bipartisan agreement on healthcare generally. But when we do have agreement, it's usually in areas like telehealth, right, where everyone agrees and then we have to pay for it. So we have a bit of a, seesaw here. One other issue I don't think I raised up when you asked me earlier about bipartisan issues that I wanted to mention here is the issue around consolidation in healthcare. So there's some interest in looking at the consolidation of healthcare systems the looking at the consolidation of healthcare payers, right? The consolidation of pharmaceutical companies, consolidation in the entire healthcare industry, and how consolidation may or may not have an impact on price. And so I think we will see some interest there because of the overarching concern about cost. The last thing I'll just mention, another area which relates to this yin yang with cost, and it's a bipartisan issue, is prior authorization. So Medicare Advantage plans, which are under Medicare Part C, they are commercial plans that provide Medicare coverage to beneficiaries, often require prior authorization. And increasingly, patients and providers have expressed concern and frustration over the burdens and hoops that MA plans are putting them through to be able to get certain care and services authorized. The insurers argue that prior authorization, helps reduce costs and prevents overutilization. And patients and providers say, no, you're just creating barriers and hoops and pushing out much needed care for patients who need it. And I, as a physician or a nurse practitioner, am recommending it. And you're keeping us from getting it to the patient in a timely fashion. And so reforming Medicare prior authorization is a bipartisan, bicameral priority. Like the House and Senate, Democrats, Republicans all want to do it. But the cost, the score came back from CBO at, I think, something like $68 million, billion, something crazy. And so now they're not going to do it because it costs too much money. So we have this constant, two-step dance that we do in healthcare, where there's things we know that we want to do that are good and right, but they cost a lot of money. And we have only a limited amount of money. And right now, Medicare takes up 12 or 13% of the federal budget, and it's growing.
And I'm a little actually surprised that it hasn't come up yet. I'm surprised I haven't mentioned it. But one thing this made me think of is, whether I think you described it as whether there would be an attempt at, smart ideas or smart reforms on this. Setting aside whether they're smart or not, at some point next year, probably summer, the federal debt limit is up for, it has to be raised. And the Republicans, particularly in the House, are already signaling that the cost of doing business on the debt limit is going to be something on entitlement reform, potentially including changes to Medicare and Medicaid. Now, whether they can follow through on that threat and actually insist on any sort of meaningful changes to those programs and or Social Security is to be determined, but that is something at some point next year we're probably going to see a debate on in Congress at the very least.
Yeah, I think that's right. I mean, if you look at the entire, pie that is the federal budget, 50% of it is mandatory spending. So that's Medicare, Medicaid, children's health insurance, ACA, Veterans Affairs, Social Security. So when we talk about the federal budget, 50% of it right now is just completely off the table. So when appropriators are designing their bills, the 12 bills we've been talking about, they're only playing with half of what's actually spent in any given year. And that 50% just keeps growing. I don't know, I'm old enough. It's like I envision a Pac-Man, like it's going to just start to eat up the rest of the part of the budget without, something changing. I think that's right.
As a follow-up to that, and you may not be able to answer this particular question, but I'll ask it, which is, do we have any sense of the end of the PHE and the potential shift of so many folks off of Medicaid, right? We expanded Medicaid dramatically as a result of the PHE.
Yep.
Now we're going to bring it back, and do we expect that to change anything about federal healthcare dollars spent particularly on Medicaid?
Yeah, it's a great question. I think just yesterday, Urban Institute put out a report that is looking at the unwinding of the PHE and then where those people go. So how many people are going to lose Medicare eligibility because of the redeterminations? And then where are those people going to go for coverage? And I don't want to misremember the numbers, but I'll just say a percentage of them are going to go into employer-sponsored insurance. So maybe at the start of the pandemic, they didn't have employer-sponsored insurance, but now it's available or would be available to them. They just haven't enrolled in it. Some will go to CHIP, the Children's Health Insurance Program. A good percentage will go into ACA plans. Interestingly, in the report, they noted that there's about 1.5 million people who are eligible for ACA but won't enroll. So there's obviously some question as to why. And then there is a good number of people who will not have any insurance. And so we will see a significant number of, we'll see the uninsured go back up, but it may actually produce some savings theoretically, right, on Medicaid, but we know that people still go to the emergency department often if they're uninsured. And so there's still a cost to the system. And, if you take Medicare and somebody shows up uninsured and, you have to be in compliance with EMTALA, you have to treat and, stabilize them. So there's still a cost to the system, even if it is being shifted around.
We have one more question, and we'll see how if we can answer this one. It's the Patch Act for Medical Device Cybersecurity passed the House easily. In the Senate, it was struck from the user fee reauthorization legislative vehicle. Is there an alternative vehicle still available likely for this session? Essentially, that the person's asking it because, as you probably know, the cybersecurity incidents and health systems in particular lately have just gone through the roof.
Right. Yep. That is a bipartisan issue. So kind of cyber and data and all those issues for health and hospital systems is something that both parties and both chambers agree on.
And not to interrupt,
No,
I will say, and it's certainly, I know this is specific to healthcare, but what schools, municipal governments, there is a lot of bipartisan interest broadly in ransomware, not just in the healthcare space.
Yeah. So it goes back to, again, this question of what's this year-end package and how big a package it is. So it's probably, been tossed in, under consideration behind those closed doors that we talked about. But if it doesn't go this year, I think that issue, and then as Nick said, kind of the broader issue of ransomware and cyber security is ripe for bipartisan, bicameral action. And I think the Biden administration would welcome, the chambers and the parties to work together on a solution there for sure.
Yeah. And my understanding there is it wasn't any specific opposition to that provision. It was just the desire by Republicans, especially Senator Burr, especially to have that bill be clean. So it and a number of other things fell out of that reauthorization.
One quick follow-up to a conversation we had before about the PHE, Elisa, and that just is, so the Biden administration has pretty much telegraphed to folks, the states and to others, that PHE is over. It's been over. It's enough already. But yet they've, at least for the last two cycles, of the reauthorization, said, okay, we hear you. You're not ready yet. If you were to take out your crystal ball, do you really think they're going to say in February, enough's enough? We need to get this stop. This needs to end.
Yeah, it's a great question. Again, don't go to Vegas. I think, well, it's interesting that MPOX, because now we're calling it MPOX, not monkeypox. MPOX emergency declaration, I think, is ending or has ended. I just saw something, I think, this morning that it's coming to an end, which is great, a great win for public health. So I think a lot of it depends on probably the next 3 months, right? We are right now, just in a bad crisis around flu and RSV, and COVID cases are ticking back up. So I think a lot of it depends on what providers are saying to the administration as to what they need. But I certainly think that 2023 is the year that we are no longer in a public health emergency.
I would just add one maybe conflicting data point is the administration just extended the freeze on student loan repayment, citing specifically the public health emergency, and they extended that through June 30th of 2023. So a non-healthcare issue is tied to a healthcare issue, right? Yeah. So there you go. So maybe we will, maybe in
February, we won't hear that it's ending in 60 days. And then April will come and go. They'll extend it another 30, which gets them through June. And then maybe we see the end. But I think this time next year, we are not under a public health emergency. I'll go bold.
I'll agree with that.
Parting thoughts?
I would just encourage people who are not currently engaged in coming to petition Congress for redress of grievances to do so. I know it often can feel like members of Congress aren't listening or they don't understand. They certainly don't understand if people don't come and explain it to them. So it's incredibly important. I was right before this webinar, I was on a different webinar with a group of hospital system CEOs who were sharing some concerns with me, and I asked them how many of them had actually explained that to their elected officials, and very few of them had. And I said, well, you know, you get the right to complain that Congress isn't doing something if you've asked them and explained it, and then they don't do it. But if you haven't gone and explained it to them, you can't really blame them for not doing anything, because, you know, ignorance is bliss. So even though we're in the last, you know, mile here of the marathon for this session of Congress, it's not too late. Make sure your elected officials know what you care about. If you want the Patch Act attached to the final package, call and write and make sure that you've communicated that. And then we have a whole set of new folks coming into town in January. And so make sure you get to know those people too. And we'll see what happens in Georgia today. Every vote counts.
Okay. Well, Nick, Elisa, thanks so much. This has been wonderful. I appreciate your time, and let's say goodbye to all, and thanks again. Take care.
Thanks.
you.
Good to be with you. Take care.